السلام عليكم. انا عبد الرحمن شريف هتكلم معاكم عن Prosthetic Infections. بداية هنتكلم عن two topics هما Prosthetic Joint Infections والNative Vertebral Osteomyelitis. Prosthetic Joint Infection for short PJI هو joint replacement عامة is a highly effective intervention significantly improve patient's quality of life, providing symptom relief, restoration of joint function, improved mobility and independence. PJI remains one of the most serious complications of prosthetic joint implantation. Management almost always requires both surgical intervention and prolonged antibiotic use. Diagnostic approach لعيان suspect ان هو عنده PJI. اولا البيشنت هيجي في الكلينيك suspect يكون مثلا بيشتكي بساينس تراكت او بون درينج، هيكون في عنده acute onset of painful prosthesis، هيكون في عنده chronic painful prosthesis بالذات لو ما فيش pain free interval. ساعتها لازم يتعمل له orthopedic referral، يتعمل through history and examination including الديت بتاع البروسيس كان امتى، التايب او الامبلانت كان محطوط فين، واي history of antibiotic use. يتعمل plain x-ray للبروسيسز وبيزلاين inflammatory markers ESR and CRP. ولازم يسحب 2 sets of blood culture for both aerobic and anaerobic bacteria. ولازم keep in mind ان البيشنت ممكن for 2 يعني لو ممكن انه empirical antibiotic تبقى postponed for 2 weeks ده هيبقى الاحسن، انها هتخلي الكالتشرز later on investigation yield better results. لو infection مش suspected خلاص there's no need to go any further. لو البيشنت suspected ان في infection هي في حل من اتنين. لو البيشنت scheduled ان هو هيدخل يعمل surgery فمفيش need للانتيبيوتيك intake، فممكن يستنى لحد ما يدخل يعمل السيرجري ساعتها يتاخد هيستوباثولوجي يتبص عليه. ده مش الموست كومن سيتويشن. في الاغلب البيشنت هيحتاج ان هو يتعمل له ارثروسينثيسيس، ساعتها هيتبص على السيل كاونت الديفرنشال بتاع السيل كاونت وهيتسحب ايروبيك وانيروبيك كلتشرز. ممكن ساعات يبقى انديكيت يتعمل كريستال اناليسيس لكن مش الكيس دايما. later on لو في evidence of infection فساعتها البيشنت هيبقى progress بعد كده ان هو يحتاج يدخل يعمل surgery. في السيرجري هيتعمل كذا حاجه. اول حاجه هيتعمل intraoperative inspection، هيتاخد periprosthetic tissue sampling عشان يتعمل histopathology، وهيتاخد لازم at the very least 3 cultures والاوبتيمم انها تبقى 5 to 6. الالتراسونيك اوف البروسيسز ده حاجه عشان يعني يوبتين بيها البايو فيلم برضه عشان ييلد بيتر ريزلتس في الكالتشر. يعني in short من الكلام دوت البي جي اي هي عباره عن presence of sinus tract communicating مع البروسيسز، presence of acute inflammation seen on histopathological examination of periprosthetic tissue at the time of surgical deployment of prosthesis removal or prosthesis removal, the presence of perineuns without another known etiology surrounding the prosthesis, 3 or more intraoperative cultures or combination of preoperative aspiration and intraoperative cultures that yield the same organism. The presence of PGI is possible even if the above criteria is not met. لازم برضو ان احنا نعتمد على clinical judgment حتى لو البيشنت مش كان جمع كل الكرايتيريا ديت. ايه هي ال different possible surgical interventions؟ الدبرايدنج implant retention strategy دي بتبقى preferred لعدد قليل من العيانين اللي هم مثلا يبقى عندهم symptoms within 3 weeks بس، ويبقى او لو البيشنت عنده الجوينت ايج بتاعه اقل من 30 يوم. ال one stage exchange دي بتبقى عباره عن direct exchange strategy او direct exchange surgery بيحصل فيها انه بيبقى ليها برضه certain conditions انه العيان يكون عيان فات، ما يكونش عنده فيه comorbidities، يكون عنده good bone stock، يكون عنده good soft tissue envelope، واهم حاجه انه يبقى already perioperative او preoperative يبقى الاورجانيزم identified ويكون susceptible للانتيميكروبيالز. التو ستيج اكسشينج strategy هي دي الموست preferable والموست commonly used. دي بتinvolve 2 stages. ان هي اول ستيج هي عباره عن removal للimplanted prosthesis، مع طبعا هيتعمل عليها كل الكالتشرز والinvestigations، وبيتحط بعديها antibiotic semen وبتفضل فتره. وبعد كده بقى السكند ستيج ان بيحصل implant للنيو prosthesis. البيرمننت ريسكشن ارثروبلاستي دي بتبقى ريزيرف للعيانين اللي هم مش امبيولنت، مش بيتحركوا، ويعني مش فات ان هم يدخلوا مالتيبل سيرجريز كذا مره. الامبيوتيشن بيبقى kept as a final resort. المانجمنت للبي جي اي سيرجيكلي هو زي ما قلنا الديوريشن لو اقل من 3 ويكس او الجوينت ايج اقل من 30 يوم مع ان البروسيجرز مفيش ساينس تراكت سسبتبل انتي مايكروبيال ايجنتس وويل فيكس البروسيجرز فساعتها الدبرايد اند ريتنشن هيبقى هو الموست اوبتيمال. لو الديوريشن اكتر من 3 اسابيع الجوينت ايج اكتر من 30 يوم وفي ايفيدنت او ساينز اوف انفكشن واضحه قوي فهو هيحصل بعد كده ريموفال اوف بروسيجرز بي ستيج 1 اكسشينج او ستيج 2 اكسشينج استراتيجي. الستيج 1 اكسشينج استراتيجي بتبقى بريفيربل زي ما قلنا في عيانين عندهم جود سوفت تيشو، العيانين الاورجانيزم اوريدي بري اوبريتيفلي ايدنتيفايد، عندهم جود بون ستوك، عندهم جود تيشو انفلوب. لكن بقى لو البيشنت عنده بور سوفت تيشو في difficult to treat microorganisms ولو مثلا anticipated good لو مش انا اسف التو ستيج اكسشينج بتبقى كابت للعيانين اللي هم ما عندهمش evident comorbidities وهيستفيد اكتر من السيرجري ديت. In case of pneumocystic fasciitis, severe bone loss, inability or failure of soft tissue coverage, or failed attempt resection arthroplasty or arthrodesis, no medical therapy available فساعتها الحل هيبقى consider الامputation. لو الدنيا مش as advanced للدرجه ديت هنconsider البيشنت comorbidities والsurgical availability بمعنى البيشنت عايز ان هو يدخل سيرجري ولا لا. لو البيشنت بالنسبه له هيبقى اوكي فساعتها الريسكشن ارثروبلاسي هتبقى حل احسن. لو البيشنت مش لو في multiple comorbidities او البيشنت refusing surgery فساعتها هيبقى medical therapy only. الميديكال مانجمنت اوف Staphylococcal PGI 2 to 6 weeks of pathogen specific intravenous antimicrobial therapy in combination with rifampin followed by rifampin plus a companion oral drug for a total of 3 months in cases of total hip arthroplasty infection and 6 months for total knee arthroplasty infection. Other PGI as in shoulder or elbow may be managed with the same protocol as total hip arthroplasty infection. Recommended oral companion drugs other than rifampin, with rifampin I mean include ciprofloxacin and levofloxacin. Other companion drugs that can be used instead of quinolones as in case of toxicity include cotrimoxazole, minocycline, doxycycline, oral refrigeration cephalosporin, or anti-staphylococcal penicillins. If rifampin cannot be used for 4 to 6 weeks of pathogen-specific if rifampin cannot be used, then pathogen-specific intravenous antimicrobial therapy is recommended. Indefinite chronic oral antimicrobial suppression may follow the above regimen as in cases of recurrence. Medical management of other PGI 4 to 6 weeks of pathogen-specific intravenous or highly bioavailable oral antimicrobial therapy. Indefinite chronic oral antimicrobial suppression may follow as in cases of recurrence. Medical management of PGI following amputation. Pathogen-specific antimicrobial therapy should be given 24 to 48 hours after amputation, assuming all infected bones and soft tissue has been surgically removed and there is no concomitant sepsis syndrome or bacteremia. If sepsis is present or bacteremia is present, treatment duration to be adjusted accordingly. With consideration that 4 to 6 weeks of pathogen-specific intravenous or highly bioavailable oral antimicrobial is to be given if despite surgery there is residual infected bone and soft tissue, as in cases of hip disarticulation or long stem total knee prosthesis where the prosthesis is extended above the level of the amputation. Treatment in cases of bacterial arthritis, as in septic arthritis, IV therapy for 2 to 4 weeks, 7 to 10 days for gonococcal arthritis, 4 weeks generally for Staph aureus, including MRSA, and gram-negative bacilli if gram-negative organism is sensitive to fluoroquinolone. In cases of gram-negative organism, if they are sensitive to fluoroquinolone, oral therapy can be given in the latter half of the treatment course. Now we'll be talking about native vertebral osteomyelitis. NVO is often the result of hematogenous seeding of the adjacent disc space from a distant focus, as the disc is avascular. The diagnosis of NVO can often be delayed several months and may initially be misdiagnosed and mismanaged as degenerative process. NVO is typically diagnosed in the setting of calcitrant back pain, unresponsive to conservative measures, and elevated inflammatory markers with or without fever. Magnetic resonance imaging remains to be the best investigation modality to be used. Other imaging modality that can be used in cases where MRI is not applicable, as in cases of metallic prosthesis, include PET scan or CT or bone scan. Except in septic patients or patients with neurologic compromise, empiric antimicrobial therapy should be withheld till a diagnosis is confirmed. NVO is commonly monomicrobial and most frequently due to Staphylococcus aureus. When should you suspect NVO? Patient with new or worsening back or neck pain and fever, patient with new or worsening or back or neck pain with elevated inflammatory markers, patient with new or worsening neck pain with bloodstream infection or infective endocarditis, patient with fever and new neurological symptoms with or without back pain, patient who present with new localized neck or back pain following an episode of Staphylococcus aureus bloodstream infection. Appropriate diagnostic evaluation of patient with suspected MVO. Performing a pertinent medical motor sensory neurological examination, obtaining a bacterial aerobic and anaerobic blood culture and baseline ASR and CRP, obtaining blood cultures and serologic tests for Brucella species in patients with subacute NVO residing in endemic areas for brucellosis, obtaining fungal blood culture in patients with suspected NVO and at risk for fungal infection, performing a purified protein derivative test or obtaining an interferon gamma release assay in patients with subacute NVO and at risk of Mycobacterium tuberculosis, a spine MRI in patients with suspected NVO. If adequate tissue can be safely obtained, pathological specimen should be sent from all patients to help confirm a diagnosis of MVO and guide further diagnostic testing, especially in the setting of negative cultures. Image-guided aspiration biopsy for diagnosis of NVO. An image-guided aspiration biopsy is recommended in patients with suspected NVO when a microbiological diagnosis for a known associated organism as Staph aureus cannot be established. In the absence of concomitant bloodstream infection, it is recommended to obtain a second aspiration biopsy in patients in whom the original image-guided aspiration biopsy drew a skin contaminant. In patients with a non-diagnostic first image-guided aspiration biopsy and suspected NVO, further testing should be done to exclude difficult-to-grow organisms as fungi, TB, and brucellosis. In patients with suspected NVO and a non-diagnostic image-guided aspiration biopsy and laboratory workup, repeating a second image-guided aspiration biopsy, performing percutaneous endoscopic discectomy, and drainage proceeding with an open excisional biopsy can be considered. Surgical intervention for MVO. Surgical intervention is reserved for patients with progressive neurological deficit, progressive deformity, and spine instability with or without pain despite adequate antimicrobial therapy. Surgical debridement with or without stabilization in patients with persistent or recurrent bloodstream infection without alternative source, or worsening pain despite appropriate medical therapy. It is advised against surgical debridement and or stabilization in patients who have worsening bony imaging finding approach 6 weeks in the setting of improving clinical symptoms, physical examination, and inflammatory markers. Antimicrobial therapy. In patients with hemodynamic instability, sepsis, septic shock, or progressive neurological symptoms, it is recommended to initiate empirical antimicrobial therapy in conjunction with an attempt to establish a diagnosis. A total duration of 6 weeks of parenteral or highly bioavailable oral antimicrobial is given. A total duration of 3 months of antimicrobial therapy is given for most patients with MVO due to Brucella species. In cases of suspected treatment failure, you have to obtain markers for systemic inflammation, ESR and CRP. Unchanged or increasing values after 4 weeks of treatment should increase suspicion of treatment failure. Obtaining a follow-up MRI with emphasis on evolutionary changes in the paraspinal and epidural soft tissue findings. Obtain additional tissue samples for microbiologic, bacteria, fungal, and mycobacterial, and list of surgical examination either by image-guided aspiration biopsy or through surgical sampling. Thank you.